And Dr. Jebinth is a high volume young surgeon from the Arvind Eye Care Systems based at Coimbatore, and a wonderful surgeon. And he's going to be showing you one such situation. On to you, Dr. Jebinth.
Good evening, ma'am. Thank you for this opportunity. This is a case of traumatic cataract with hydrodialysis. After a 2.8 clear corneal incision is made, and after staining the capsule with trypan blue, scleral groove is made 1.5 mm away from the limbus, which corresponds to the scleral spur. And the AC is formed with high molecular weight OVD. The plan is to anchor the iris with a 10-0 prolin double arm suture. A 26 gauge needle is passed through the groove, and the needle is then passed to the peripheral part of the iris. I'm using a second instrument to give counter traction. It can be either a spatula or a micro forceps. Now the suture is threaded into the 26 gauge needle. And it should be threaded out, withdrawn out. Now the 26 gauge needle is passed 1.5 mm beside the first suture bite through the scleral groove. It penetrates the peripheral iris, and the second end of the double arm suture is docked and pulled out. Care to be taken not to involve the corneal tissue. Now both the ends are tied. Make sure it's not over tight. Aim for a reasonably round pupil. Now then the suture bites are buried into the groove. And as in this case, it's intralenticular pressure is more. So I'm planning to do a double rexis. So initially a small rexis is made to avoid Argentinian flag sign. Then the liquid cortex is removed. Then a small nick is made at the rim of the rexis margin, and it's enlarged to the desired size. As multiple bout of hydrodissection is done and phacoemulsification is done. Initially, I planned for a direct chop technique. Because it's too soft, I'm not able to hold. Then I made a small trench and divided into two heminucleus. Then emulsify the cataract. And hydro is flushed to loosen the cortex. Then coaxial IA is done. With polishing. And a single piece IOL is placed inside the bag. The visco is washed in the anterior chamber and behind the IOL. And the conjunctiva is upmost. Thank you.
Thank you. Wonderful presentation. It is just that I'm just going to ask you one question. Because the cataract was so intermittent, could you have done finished the cataract surgery and then done a iridodialysis repair? I mean,
yes, ma'am. That's also an option, ma'am.
Yeah.
But I feel this little more comfortable than doing the cataract first.
I would retract. The problem will be that this will be a flappy iris tissue
We will
moving
put
into
a
the.
capsule hook
That's
and
what. That's
Yeah.
what. We put an iris retractor hook through the cornea and then
Yeah.
retract it
Absolutely.
and keep it there, because
Yeah.
you really run a risk of touching the anterior capsule. You
With
are
your
a
Prolene
great skilled
suture.
surgeon, very steady hands and all those. So,
Yeah.
but it is not the same with everybody. So sometimes, if you tilt a little bit, the tip may touch the capsule and it may break there. So once
Yeah.
the capsule is torn in the periphery, then you don't have a security of this rexus which you have towards the end of the day. So I would definitely hold it with a hook and then do it later.
And it's an intumescent cataract. So
True, sir.
I won't take a chance like that. Absolutely. Of course, you're a skilled surgeon, Dr. Jebin. There's no doubt about that.
Yeah.
Thank
Yeah. Very good. So we go on to our
Thank you,
next
thank you.
presentation. Yeah, thank you.